The objective of the trial is to determine the safety and tolerability of factor X and whether it can provide any beneficial effects on the disease or improvement of the quality of life in patients with advanced untreatable stages of cancer. The study design is a double-blind, randomized, placebo-controlled clinical trial comparing a dose of 3 capsules daily of the factor X against placebo for a duration of 24 weeks. The inclusion criteria: adults from 18 to 70 years of age diagnosed as an advanced stage of malignancy. The National Cancer Institute selected to start with hepatocellular carcinoma as it is the most common and the most prevalent here in Egypt, to study the first cases diagnosed by biopsy and or triphasic CT or MRI picture of hepatocellular carcinoma plus or minus alpha fetoprotein level more than 400. Patients with advanced cancer stages, patients who have no available standard cancer treatment options or planned to have palliative or supportive care, patients who refused further cancer treatments. Measurable or accessible lesions that can be accurately measured in at least one dimension, the longest diameter to be recorded, as more than 20 millimeter with conventional techniques or as more than 10 millimeter with spiral CT scan must be present. World Health Organization performance status from 0 to 2 and life expectancy of more than 3 months. Patients should be able to communicate and adhere to the trial protocol and signed informed consent obtained. The exclusion criteria are critically ill patients with decompensated heart, liver, kidney, or multiple organ failure, including childbirth class C, patients who refuse to sign the informed consent, or those who are bedridden with inability to swallow capsules or any other condition potentially hampering compliance with the study protocol and follow-up schedule. Active anti-cancer therapy by radiotherapy or chemotherapy starting 1 month pre-screening till completion of the study, 24 weeks or death, whichever comes first, pregnant or lactating women. Interventions. Consecutive patients presenting to the outpatient clinics will be checked for eligibility during the screening visit. The visit number 1, which is -1 or 2 weeks before the week 0 of randomization. Eligible patients who fulfill the eligibility criteria and sign the informed consent form will be included and randomized into 2 groups as follows. Group number 1, who will take the factor X, the Ambrosia maritima extract capsule in a dose of 3 capsules in 2 divided doses, 2 before breakfast and 1 before supper, in addition to their palliative care, which is considered here as an experimental group, for a follow-up duration of 24 weeks or death, whichever comes first. This will be 60 patients. And group 2, also 60 patients, will take placebo in the same dose and duration. Treatment and follow-up visits. Enrolled patients will be subjected to the follow-up assessment at visits 3, 4, 5, 6, 7, and 8 at weeks 2, 4, 8, and 12, where the interim analysis will be, and the 24 weeks with the final analysis of the study and study closeout. Patients will be assessed at each visit for Table 2, any occurrence of adverse event with causality assessment according to the Uppsala Monitoring Center causality category, treatment compliance and concomitant medications, general condition and WHO performance status, the quality of life C30 Annex 2, clinical evaluation for any emerging clinical manifestations or deviation from baseline clinical laboratory or imaging data, laboratory tests for hematology, biochemistry, and appropriate prognostic tumor markers like the alpha-fetoprotein, CAA, and so forth. Lesions will be measured clinically and or by imaging technique like the ultrasonography or triphasic CT or MRI at defined visits. Evaluation of target lesions. Measurable lesions up to a maximum of 5 lesions per organ, totaling 10 lesions in total body. Representative of all involved organs will be identified as the target lesions and will be selected on the basis of their size, those with the longest diameter, and the suitability for accurate measurements by imaging or clinically. The sum of the longest diameter for all selected target lesions, sum longest diameter, will be calculated and reported. This will be repeated at scheduled visits, like we will see in table of visit schedules. And each patient will be classified according to the best response in target lesions observed during the follow-up visits into complete remission or complete response, disappearance of all lesions, or partial response, which is at least 30% decrease in the sum of the longest diameter of target lesions, taking as reference the baseline sum of longest diameter. Stable disease, neither sufficient shrinkage to qualify for partial response, nor sufficient increase to qualify for progressive disease, taking as reference the smallest sum of longest diameter since the treatment started. Progressive disease is defined as at least 20% increase in the sum of the longest diameter of target lesions, taking as reference the smallest sum of longest diameter recorded since the treatment started, or the appearance of one or more new lesions. Early deaths from malignant disease, early deaths from drug toxicity, early deaths because of other causes, or unknown, not accessible, insufficient data. The progressive disease will be reported according to the overall response for all possible combination of target and non-target lesions. So the complete response for target lesions and complete response for non-target lesions and no new lesions will be overall response, complete response. And complete response in target lesions, incomplete response in non-target lesions, while no new lesions will be considered as partial response. Partial response in target lesion and non-partial response or non-progressive disease in non-target lesions and no new lesions will be also considered as partial response. While stable disease will be, as we see here, stable disease, and progressive disease will be progressive disease of target lesion or any presence of new lesions at any site. Randomization and blinding. A stratified block randomization technique will be used to assess balanced groups. Both patients and the clinical assessors will be blinded for which treatment is given to each patient. Both study medications will be similar capsules packed in similar patient kits, coded according to a randomization sequence. Patient allocations will be concealed in sealed envelopes and kept by the study statistician. Primary endpoints: the incidence of treatment-emergent adverse events in each group over 24 weeks will be compared between groups. The change from baseline in the WHO Performance Status Scale and in the EORTC Quality of Life Questionnaire C30 Quality of Life Scoring will be compared between groups. Time to an event in days, which will be time to death, time to disease progression, or time to quality of life deterioration, measured from the baseline visit date, week 0, until the event, death or disease progression or marked deterioration in quality of life. This will be compared by Kaplan-Meier square survival curves and the Cox regression. Comparison of progressive or progression-free survival and overall survival rates between groups will be analyzed. Secondary endpoints: response rates in both groups, change from baseline of some longest diameter, and histology or cytology if needed will be compared between groups at visit 5, which is week 12, and visit 7, which is week 24. Change from baseline in laboratory parameters and the tumor markers will be compared between groups at visit 5, week 12, and at visit 7, week 24. Adverse events reporting: the treatment emergent adverse event is defined as any adverse event reported by patient or observed by investigator during the study visits or any deviation from a baseline normal laboratory test occurring after administration of the first dose of the study drug till 30 days after the last dose. All treatment emergent adverse events will be reported using the Medical Dictionary for Regulatory Activity, MEDRA, with the lowest level and preferred terms included. The treatment emergent adverse effects or adverse events deemed to have certain probable or possible causality to the drug according to Uppsala Monitoring Center causality categorization will be considered in analysis for incidence rates in an intention to treat basis, graded according to seriousness into serious, non-serious, and to severity using the common terminology criteria for adverse events number version 3. Adverse events will be spontaneously reported by the patient or found or observed by investigator. All adverse events during visits or between visits will be reported in the case report form, and any serious adverse event will be reported in due time to both the sponsor and the ethical committee within 7 days. If an adverse event is observed during the study period, it has to be followed until it is resolved or reasonable explanation given according to the discretion of the investigator. The study will be performed in accordance with the recommendations guiding physicians in biomedical research involving human subjects adopted by the 18th World Medical Assembly, Helsinki, Finland, in the year 1964, and the later revisions, Helsinki Declaration and the International Conference on Harmonization Guidelines on the Good Clinical Practice. And this table shows the screening visits and the study visits by week of treatment, where we will have the informed consent, inclusion, exclusion criteria from the screening visits. Randomization will be done at the randomization visit to week 0, and after that the treatment will be dispensed, and all data, as we see here, will be plotted according to the schedule. Thank you very much. Thank you very much.